lot of these cases are hot off the press. Patients I've seen in the office either this week, last week, or the week before. Some are a little older for teaching purposes, but most are very recent cases. I want to thank my office staff, Frank Alexander, Yale, and Billy Wagner for helping me get these cases together. Also, my fellows helped with putting some of these cases together. So let's start with a batter's shoulder. This is a 26-year-old, he's professional, and he throws right and bats right. Throws right and bats right. So I'm emphasizing that because it's important to know how he throws and how he hits. He's got a left shoulder, it's his lead shoulder, subluxation hitting, and he grinds it out through the entire season. Like his shoulder's just killing him, but he doesn't want to give up the season. This is what his exam looks like. So exam on a normal shoulder is great to observe the features. But when you have somebody who has a real pathologic situation, of course, that's much more learning. So we're doing some strength testing as a batter's shoulder. Tony, what are you going to expect to see on a batter's shoulder on a physical exam? What are you hunting on exam to be positive?
Yeah, so I would anticipate through central range of motion, his strength is actually going to be pretty good. And so this is one where you have to work towards the edge of the capsule and the labrum because your anticipation is that he has a disruption of the labrum from behind the biceps down on the back side. So sometimes they don't have that much instability, but they hurt a lot.
If I can show the exam, I can't replay the video, but normal, all the way across. This is not an active compression test, which is 10 degrees of adduction, put him all the way across. Like if he's hitting, then he has weakness and he doesn't like it because batter's shoulder is you activate your deltoid so forcefully in such extreme adduction, you force the humeral head out of the back. So he didn't like that.
So Chris, you know, it's similar to John Conway's technique of looking for that posterior labral tear in our pictures when they, you know, they're pretty good in internal impingement sometimes when their arm's here, but when you make them stretch out in this position here, then they can't hold it in that position. So bringing it further across, I'm sure that would bring it out.
Okay, so we did some jerk tests and I'm checking his ligamentous laxity, elbow hyperextension, thumb to forearm, metacarpal hyperextension, and those are part and Baton scores.
He's pretty lax.
So check out this MRI scan. Chris, what do you got on this MRI?
Yeah, and this, so axial images here, and you can see in the anterior aspect of the humeral head, you see that sort of edema in the humeral head. So you see reverse Hill-Sachs defect. And then if you look at the posterior aspect, you can see labrum and capsular tearing. So this is sort of pathognomonic. So this shows you that edema in the anterior humeral head went towards the back, hit the glenoid in the posterior aspect. So this is consistent with posterior instability. And oftentimes I think this is a pretty dramatic example because I think sometimes the batter's shoulder, it can be a subtle subluxation. This has me even more concerned. This might be, in addition to just simple subluxations, may have actually been a true dislocation as well.
Yeah, he reverse Hill-Sachs. Can you imagine? I haven't seen that in a batter's shoulder. So this is a good case. So Tom, we got the diagnosis. What's the treatment now?
Well, I think in my experience, these tend to not do well non-surgically, and that's, you know, it sounds like you guys tried to treat them throughout the season. So I think this needs to be repaired arthroscopically.
Okay, off-season arthroscopic repair. I agree with that. We put the camera inside. George, you see the pathology? Is this?
He clearly has fraying of the posterior labrum from just behind the biceps anchor all the way down to almost the 6 o'clock position inferiorly. It looks like there's a split in the labrum. I'm sure you're going to put a probe in here and tell us whether it's detached from the glenoid rim or not. The biceps anchor, which you show right there, looks intact. And there you can see the separation of the split in that labrum. So the labrum's really split into two, and that segment that you have the grasper on is clearly detached and unstable.
Yeah, he fragmented the labrum and now the capsule is incompetent. And that's that reverse Hill-Sachs lesion. So this is more dramatic, this is more impressive. We've seen some illustrations of how we put anchors in, we do our suture passing and we fix it. So what's the prognosis? Now, Mark, what's your prognosis for this professional player?
Guarded, We actually just published on this in the Yellow Journal this month. We wrote an article on batter shoulder. If anybody wants the reference. So these are hard to come back from. I was going to ask you technically, did you try to incorporate that bucket handle fragment?
Did, yes. Did not take it out.
Yeah. Well, I think probably what I would have done as well. I think he has a somewhat guarded prognosis, like others have pointed out. This looks like truly a dislocation and not just a little subluxation event. That big Hill Sachs, I think, is pretty indicative of that.
I want to go down the panel. I have a different opinion, and I'm gonna be the non-agreeer whenever I can. I feel good about this guy. Tony, how do you feel about batter's shoulder? Do you feel like they get back, or is it hard to get these guys back?
Yeah, well, I probably haven't taken care of as many as Mark, so my remarks are going to be in my own patient population, and I think that looks great. I think you did the right thing by incorporating that rolled off tissue. The tissue's split, but it's, that's 40% or so of the normal concavity of the posterior aspect of the shoulder. So it's not just tightening the capsule, but you're actually creating that concavity and the stability to the shoulder. So I would be fairly optimistic that he'd be able to turn back. It's his non-throwing shoulder, and that would be my anticipation.
Okay, down the list, real quick. Good or fair prognosis? You're going to sign this guy?
Yeah, very optimistic for him for two reasons. One, because it's his non-throwing shoulder, and number two, there's no cartilage damage here. So I think I'd be very optimistic for him.
Yeah, I like that. Do you want to expand on what it means to be his non-throwing shoulder?
Yeah. So
How do you get a batter's shoulder on your non-throwing shoulder?
yeah. So
On your throwing shoulder, rather.
typically, so if you switch, if you're a goofy hitter, so you can be a right-handed thrower, but a left-handed batter. So that means your throwing arm is also the front arm when you hit, which is the one that's most likely to have instability. That's very challenging because from a batting perspective, you want to make the shoulder tight and stable, but from a throwing perspective, you need it to be very loose. So that would be concerning. But since it's his non-throwing, very optimistic. And usually with that, you can be a little bit more aggressive with the repair. So really tighten the capsule and the labrum to make it tight because he doesn't need to throw with this arm.
I agree with you. He doesn't have glenoid retroversion. There is anterior humeral sided subtle bone loss, but he doesn't have a glenoid bone loss. And so any other comments, Tom? George?
I think in general, these do fantastic. I do have some concern with the reverse Hill Sachs and the fact that labrum was all kind of shredded. It would be interesting if next year you tell us he did horribly, and then we might, just like with the anterior instability in contact athletes, they come back after 5 dislocations and everything's like destroyed. You wonder if this guy would have been, and I understand he probably wanted to keep playing, but maybe it would have been better to fix him earlier. I don't know.
I agree with what Chris said. The fact that he throws right, bats right, and this is his left shoulder, I think he has a fairly positive prognosis.
Okay, here, let's keep the, go ahead, Peter.
Can I ask one quick question? I mean, there's obviously you showed considerable reverse Hill Sachs. If this was an anterior dislocation, I think there'd be a lot of people talking about remplissage. Is there a role for reverse remplissage? Maybe not in this guy as a baseball player. Is there ever a role for that procedure? Who gets that procedure? I can't figure that out.
Remplissage in general or a reverse remplissage?
Reverse
remplissage. It would be, for me, it would be an offensive lineman or a power athlete that has posterior instability with relatively good version. You can fix the labrum, but they have a significant Hill Sachs lesion that I would consider do a reverse remplissage on that. You have to be very careful to not put it at the articular cartilage. You just want to shorten it just a little bit.
We'll move on. There's more cases, but just to say that a locked posterior dislocation in a whole different population, that's treated with a McLaughlin type procedure if you're not doing humeral head restoration. That's how I was trained. And so I've seen that in real life. So that's a good point, Peter. Let's go with, we have another case. It's interesting. It's another batter's case, batter's shoulder. We're going to keep going because this one's different. He's a catcher, so he throws right-handed, and but he's a left-handed batter. So exactly what Chris was saying, he's got shoulder pain. It started out with swinging after he fouled off a pitch. Often this is an extreme adduction and you swing and miss. So no energy goes through the ball. You got more load in the shoulder, and then they have that posterior subluxation. He's got all the positive exams, and we're going to scroll through some, and because I know this is a little too challenging to look at all this stuff, and it's carousel. Let's just do this. What do we got now? Who wants to go?
Yeah, this is concerning. So in contrast to our last one, you don't see that Hill sacks in the anterior humeral head. So that's good news, but you do see a little chondral fragment sort of shaved off the posterior aspect of the glenoid. If you look on that axillary view on the far left, you see some glenoid cartilage missing. And then in that axial cut in the center, you're a little bit lower, you see that fragment, which may either be labrum flipped down or it could be a loose chondral piece. So this is concerning not only for this athlete getting back to sport, but we also have to have the conversation about long-term risk of problems and arthritis for this young kid.
Okay, so his diagnosis is what's called a battered shoulder, but now he's got glenoid cartilage issue and he's got a displaced labral fragment. Everybody agree?
Yes.
Here's a little bit of retroversion. He's 15. And this is his
Throwing arm too.
throwing shoulder. Love to have a laser pointer. Anybody got a laser pointer on? This one points, but it's like a dot. It's really tiny. All right, here's his exam under anesthesia. You guys saw it. Anything unexpected with that exam under anesthesia? Okay, let's see what happens inside. Here's the camera inside. And so he's got that posterior labral. There's the flap that's going into the axillary recess. Anybody want to preserve this flap? On the other one, it was more of a split in the labrum and we kept it. This one we took out and that's a loose cartilage piece. It's acting a little OCD-ish. It's not classic location for OCD. OCD in the glenoid is posterior and inferior, but it's not on the margin like this. So describe this, Tom. What are we going to do with this?
Well, it looked like you had a super loose shoulder too on your EUA. I think you've tried non-surgical treatment, obviously didn't do well. You got to fix this. I would probably tend to advance that labrum to cover that defect. The caveat here being that, like we've talked about, this is actually this kid's throwing shoulder, which concerns me. Now, the good news, I guess he's not a pitcher. I think you said catcher, infielder, but I mean, I think you got to fix the labrum, and I would probably advance that labrum to cover that chondral loss there.
I like that idea. Anybody do anything different? Okay, he's 15, so he may grow a little bit out of that generalized laxity, that looseness of his shoulder. He was translating anterior as well as posterior. And this tissue is a little bit, it's got fibrous stuff in it, so it's acting a little like an OCD lesion where Hollis showed us those OCD lesions. So we're getting the fibrous tissue out, we're preparing for healing. And then the question is, advance it, the chondral injury, you already said we would advance the tissue. Anyone would do cartilage restoration? Is a tiny little thing. No. Okay. All right. So how much capsular plication? I mean, we don't want this kid to come out the back again. Maybe his pain is just because it's torn and it's a cartilage lesion. Maybe just fixing it is going to be enough for him. Maybe there's more pain than subluxation. What do you guys think? How much do we need to tighten this shoulder? And knowing that it's his throwing shoulder. Mike, tell us how you feel about he throws right, bats left. What should we do to make your job easier?
Yeah, and he's a catcher too, so he throws a lot. So there's a lot of volume, a lot of fatigue with him, and that may be why he injured it to begin with. He's tired. Most 15-year-old catchers don't do a good shoulder program, so he's probably tired, fatigued. He's got no stability there. But to answer your question with him, I mean, I'd tighten it as little as possible, but as much as you need to, but as little as possible.
Okay, if I'm reading into you, tell us some more about when someone tightens them up too much.
Yeah, and it happens. I'm sure everybody here has seen that. So the tighter they get, obviously it's going to be challenging for them to get their range of motion to throw again, right? So we talked circle concept a little bit this morning, Dr. Ahmad's talk. You tighten up the posterior capsule a little bit, you're gonna lose total rotational motion. So even though he's a catcher, he's still going to struggle. And a 15-year-old catcher that doesn't have a good arm isn't a good prospect.
And
Yeah,
do you guys think, an excellent therapist like Mike, let's say I do because the one problem is if he's too loose, Mike can't fix that. My tendency, as loose as that kid's shoulder looked and the fact he's not a pitcher, I probably would do some capsular plication. And then I guess my question to you, Mike, don't you think you could fix that a little if I over tighten them, that you could stretch it out if you need to?
I feel like I have one of those years right now, right? Everybody in this room just off, like, yeah, yes, we don't enjoy it. I'll say from the physical therapy athletic training community. You know, our mind is there's a happy medium. Everybody on this panel here is going to do an amazing job. What we find is the orthopedists probably in the local communities that don't work with a lot of baseball players, or they work with predominantly contact athletes, and then they tighten it up like this was a football lineman. That's the problem. It's not you guys tightening this a little bit extra from somebody that gets an overhead athlete. So I appreciate that. But, you know, from the rehab perspective, if this person's drum tight at the very beginning and you know that surgeon doesn't do a lot of overhead athletes, then that's somebody we probably go quicker with their range of motion with. Just something to think about. We don't, you know, remember you gotta weigh the consequence.
I'll just add the patients who get too tight, they are miserable and angry. And when you can't get them back, they're just like, what happened to me? Here, go ahead.
You see some of these hitters that are they're power hitters that have big one-arm releases. If this is one of those guys, he needs to change his technique, just like we would change a thrower that has poor techniques.
I think that's a great point, Mike. I don't think we pay attention enough about batting technique, and with all the technology with, say, video analysis, there is a role for that. That's a great point.
Would you talk to him about changing position from catcher?
Good question. He's 15 years old, and I think when 15-year-olds who are overdoing it, like Mike said, as a catcher, there is some heavy abuse at the catcher position, especially at that age. There's not another catcher. He's the guy. He plays every game, et cetera. It goes on and on. So some of the biggest abuses from a position standpoint is a catcher, and I don't think we recognize that. So at the very least, we should monitor his amount of catching, and especially at age 15. Okay, part of the feedback we got from you guys, from the audience, is let's talk about more real practical things. Not every player throws 101 miles an hour in our practice, and the professional guys are not all over the country. They're the few. The real patients are the high school and college kids. So I'm going to show a lot of high school and college kids, and I deal with this a lot. This is Yankee Stadium, Notre Dame. Tony played Army. I had to go see a player, and they were setting up the field. Looks beautiful. Great place for a football game. And so it made me think, I want to talk about the high school baseball player who also plays football. That's a bad situation for a problem. Here's an example. He's 16. His love is being a catcher. He wants to play in college as a catcher. He's also a high school football player. Multiple sports. We endorse that. We like that. He dislocates his shoulder making a tackle. And it's his right shoulder, and he gets a hospital reduction. So this looks like Hollis Potter quality imaging here with all the bright and all the stuff. Schick, you want to tell us what you're seeing here?
We've got multiple fat suppressed sequences, axial on the 3 there, and then we have a coronal down in the bottom right. First thing that sticks out to me is the edema pattern in the humeral head. Looks like he's got a Hill-Sachs lesion back there, so that looks acute, looks real. The small area in the front that looks like a labral tear is actually the anterior band of the inferior glenohumeral ligament. On the image to the right of that up at the top, looks like he does have an anterior labral tear, and the lower left also looks like he has an anterior labral tear as well. On the coronal imaging, I don't see any problem with the rotator cuff. He's got a little signal at the empty junction of the supraspinatus, but no tear. He has a little signal in the lateral portion of his physis. And at the bottom of the glenoid, it looks as though there may be a fragment of labrum or something. Something's not right there at the bottom.
All right, to summarize this, typical features of a traumatic dislocation: Hill-Sachs anterior inferior labral tear. Lots of edema.
Yes.
Okay, so let's talk about treatment now. Tony, what is this throwing shoulder? Is there a role for non-operative treatment here, and how would we get him through non-operative treatment?
This is, I'm sorry, did you say this is throwing?
Just throwing
Yeah.
shoulder.
So no, I mean, once you say that, then the answer is, it should be fixed. I think that in this individual, they're going to go through a recovery phase. Some of this tissue is going to heal. If he doesn't do well, you're going to get in there and do the best that you can. But if you go now, you'll be able to see all the pathology and fix it. And I think you have the best chance of returning the shoulder back to its pre-injury level if you fix it now, especially if it's his throwing shoulder.
Okay, brilliant.
Does he
Chris,
have a capsular tear too, by the way?
It
or-
looks like it.
Yeah.
Chris, what do you,
Yeah, this is
What do you
challenging.
think?
I actually might, and not to make it too controversial, but being it's a first time dislocation ever for the, yeah. So with a first time dislocation, there's quite a bit of pathology, but we don't know how this would heal and how it would lay down. I would actually consider trying initial non-operative treatment and get him into physical therapy and get started on motion.
all right, who on the panels? Now we have controversy. Tony says fix it. Chris says non-op. Who's fixing it? Raise your hand. Okay, so George and Chris are not fixing it. How about the fact that he's a sophomore? Does that play into this? Wants to play college baseball. How does that play in?
That doesn't, but I think the timing of the year does. You know, if we look at now, it's October and we fix it and he's looking at a 6-month recovery and getting back to baseball. This would have, if we did surgery now.
You just said no surgery, my man.
Correct. Yep. I'm telling you why. If we did it now, he'd be back to surgery in April or May. He's going to probably miss his high school season if he did surgery now, but would make it for his summer season. For me, I would try non-operative treatment, at least give him six weeks or so to see how he does and see if he can get this stable and get back to throwing. If he does, allow him to go. That's really his only chance of playing in his high school season in the spring. If not, I'd be looking at doing his surgery in 2 to 3 months, which would still make him miss his high school season. So there may not be that big of a detriment to waiting a little bit.
What if he was a junior? And I'm just going to lay this out for you guys because I don't even talk about the Hill sacks to these patients or the labrum tear. None of the conversation with the patient is about that. The kid's saying, I need to play in college. When I'm a junior, my spring and summer is everything to me. If I miss that, my whole future is corrupted. So he's a sophomore, so he could be fixed now and preserve his, say, junior year. And if he was to succeed with non-operative treatment, that doesn't mean he's immune for life. He needs to be, and he needs to have great therapy, great everything. If he dislocates in his junior year and then can't play through it, it's a big problem. Any other comments here?
Some commercial insurers deny surgery on these. I just had that happen to me on a 14-year-old kid that really needs surgery. Just keep that in mind. If you try to schedule surgery without any attempt at non-operative treatment, it's possible it'll get denied depending on insurance.
I don't think this is a simple anterior dislocation with a small, classic anterior inferior Bankart lesion. I think this kid probably has an inferior capsular tear component of a Hagel lesion, and this is a much more complicated surgery. And I think Chris is optimistic that you're going to have this guy back in 6 months playing baseball if he has surgery done. I think it's a longer recovery time than 6 months because I think the instability pattern is going to be more complicated than, again, a first-time dislocation with a small Bankart lesion.
He's a sophomore, so we're talking about he has a year and a half to get back. Yeah, right. Yeah.
Okay, let's see what happened. So there's his Hill sacks, and we showed pictures of internal impingement. Would anybody do, Peter Chalmers, would anybody do a remplissage on the throwing shoulder of a high-level baseball player? Anybody do remplissage? People know what we're talking about remplissage. We want to manage the Hill sacks because bone loss increases your risk of a repeat dislocation. And if you want to manage, say, instability recurrences, you can do remplissage and fill in that defect with soft tissue. But we already said these pitchers need to get into external rotation. External rotation is everything. So no remplissage, no filling that. Maybe that's, and going to be well tolerated from a throwing perspective, but not so much from a instability perspective. We would like to see it go away. And if it needed to be managed, I don't have a case today, but last year we showed a case of doing grafting to that. Okay, here's the labral pathology. It's a little bit of medialized, but it's not so atypical. It wasn't as catastrophic. I think that was an early MRI after the injury, so there was a lot of like an ankle sprain. There's just a lot of stuff going on there on the MRI scan, but it looks like a very typical traumatic dislocation. So here's the question now. He's got some bone loss and he's got a labral tear. Do we need to imbricate this? Do we need to just fix the labrum? How much? How much do we imbricate this?
I would tend to just fix the labrum and not do much with the capsule. With the thought, I mean, if this kid said I play baseball for fun and I'm a football player, whole different answer. But baseball, if his primary goal, I'd probably just fix the labrum.
Okay, you say that, but when you're operating, we know what you really do. Because Mike already told us, and you already said you fix them tight and let Mike get them normalized. I agree with that. So what we're talking about is this is extremely sport specific and extremely position specific and which arm. So if they're throwing and they throw a lot, we have to preserve external rotation. You take away external rotation, they are miserable and angry. And that means we lean towards less imbrication, but also means they have a chance of recurrent instability. So that's why this is a tricky one. If this is a football player, imbricate it, do everything necessary. And Tony, you taught me about doing posterior inferior plication to help manage anterior instability, which I love doing. And a thrower like this, would you do posterior inferior plication?
I wouldn't, the chances are less likely in a thrower, but I fixed the pathology. So like I said, I mean, I would tell this athlete after talking with him and his parents, if he really wants to play college ball, his junior year is going to be very important in terms of scholarships and other things. I would recommend having it fixed. That doesn't mean they're going to have it fixed. Probably 50% of the time they don't. They say, well, let me just see how it goes for a while. And they end up going through the course of action that Chris and George have talked about. And so then they come back 3-4 months later. But if you get in there early, you can see exactly what happened. And if that tear, as it oftentimes goes into the capsule, even pulls off that posterior inferior labrum, then I fix it with the intention of fixing it back anatomically with no imbrication on a thrower. So when we go into these athletes later, what you see is a lot of laxity inferior and even posteriorly. And so we oftentimes putting an anchor back there, bringing the capsule up and everything else. But I think that's part of the pathology that develops almost after it's had that instability for a while. And if you fix it early, you can repair that part anatomically. And I think you'll have a better chance of getting it back to a throwing sport.
What pathology in this case do you think you're not going to see well 3 months from now when the kid says he can't throw, barring another dislocation or other injury? What are you going to see? You're going to see the labrum scar down to the neck as opposed to being mobile on the neck where it is right now?
Yeah, I mean, George, you and I have been taking care of these months and years after they occur. So we've learned how to do that. But I think when we get in early, we have the opportunity to do less and still be successful. So I think it's not so much that we're not going to see it, but we go in there 3 to 6 months later, we really don't know as well. And so our tendency is going to want to tighten it up or do just a little bit more. And the capsule is going to be adjusted. Like if he had a small capsular tear in this one, I would leave it alone most likely. If it's just a little bit off the humerus, I would fix the labrum and not worry, because it's usually that's where the head goes out between that middle and inferior gland humerus. It stretches the capsule. They might get a little tissue off. I don't think you need to repair that. When you come back, it looks very lax and loose, and the labrum is way off the front. And I think we have a tendency to try to overdo it. So again, this is an overhead throwing athlete in my book, and I'm going to be more aggressive. If he wants to play football, his whole thing is playing college football, I'd treat him, like you said, non-operatively at first, or at least give him the opportunity for that, although there is an argument for fixing those two. But as a sophomore, you give him a chance if he's just playing football. If he's an overhead thrower, I'm going to be more aggressive.
But absent any recurrent instability episode, don't you think whatever plastic deformation has taken place in that anterior capsule is already present?
Yeah.
Or does that increase over the next 3 or 4 months if he doesn't have another dislocation episode?
If he doesn't have another dislocation, it probably does not increase dramatically. Yeah. And again, I think that you could argue that we're operating on more than may actually need it. I happen to believe our technology now is good enough that if an athlete wants to perform at their highest level, we can help them stay close to that. We see lots of athletes who have these injuries who come back and do well, but if you talk to them, say, yeah, it's not perfect, feels okay. Sometimes it slips on me, but I'm doing okay. I want this athlete to say, I don't even think about my shoulder anymore.
So to that extent, if this was his non-throwing shoulder, would anybody do a remplissage in conjunction with what Chris showed us? Non-throwing shoulder, given the size of that Hill-Sachs lesion and the like?
Yes,
I probably would.
yes.
Yes.
I agree with that. Remplissage has been a real nice addition to success rates, and the literature shows that in a non-throwing shoulder it's really been great, and it's easy to do in a way that it doesn't add morbidity or complications, but it can increase your success rates.
And the only reason I brought that up is to reiterate what you said. The approach to this shoulder is dictated, particularly given this kid's sport and the dominant arm involvement, whereas a non-dominant arm or a contact athlete, we would potentially treat this pathology very differently. So I just wanted to reiterate your point that this has to be specific to the athlete.
And Chris, since you brought it up, that 7 o'clock or posterior inferior, if you have a patient that has a significant bony Hill-Sachs lesion, I would be very cautious about adding that posterior inferior anchor because you're really tightening up the capsule on both sides of the joint, and you can over tighten them in that situation. So you have to be careful. If it's not much of a bony lesion, I actually think you solve most of the problem with that posterior inferior anchor, and you don't have to do a remplissage. But if there's a significant Hill-Sachs, I think then you should consider doing it on the humeral side for that problem.
Mike, just to give us a sense, we're going to move on to another case. We got lots of cases. It's going to get better and better. Mike, what's your time frame? Just give us a number when he starts throwing and when he's back in the game.
For him, after that big procedure there, I'd say we'd probably start throwing, I'd say 4 months would be the earliest, somewhere between 4 and 5 months, because it sounds like we have a ton of time, because we have all the way until next spring, theoretically. So we'd probably start about week 20 is when we'd start. That gives us plenty of time to get his range of motion back. Like we want orthopedic range of motion by like week 8 to 10, and then thrower's motion week like 12 to 14. So then that gives you like a good 6-week plyo progression to get ready for an interval throwing program around week 20. And then we just go slow. And I think that's—
When's he back
that's
in the
the
game?
key. He's a catcher,
Yeah.
right? He's going to be back in a game in April because he's a high school kid. So we have a ton of time.
Yeah.
When do
Okay,
you let
so-
him bat? When do you let him start batting?
So we don't like starting hitting and throwing at the same time. Obviously, control your variables, and throwing takes longer. So usually once we get to like long toss, we'll start a hitting progression, just so that way it's not like conflicting a little bit. But let's say we were in a rush to answer your question, though. I mean, this person could be back like 2-month long toss program, maybe a 6 to 8 week catcher progression from there. So 8-9 months probably is when they could be back as fast as they could. But the majority of the time, we don't have to get that person back right at that minute. Like this kid, we can slow down.
I like that. We work backwards and forwards. We work backwards from when they need to be ready, and if they need to be ready sooner, sometimes we accelerate and share decision-making. If we got more time, we take more time.
fact
Schick,
that-
does this kid play football again? You take care of lots of football players in your career.
Yeah, I think he does.
You're not doing a football operation. We just said we're not doing a football operation. So is he at risk going back to football? Increased risk?
Probably a little bit increased risk, yeah.
All right, I'm baseball specific. I don't take care of a football team. I told this kid, you're not playing football anymore. If you want to play college baseball, you stop playing football. And it's the reason why this is interesting sport. Play basketball, run track, but learn how to play cricket. Football is just like that. Some of these injuries, you can't, it ends careers. I've had guys that don't come back after this injury. 3 dislocations. JT Tokish, by the way, colleague of ours in the shoulder world, he said, you don't have to operate on a first-time dislocator, but always operate on them before the second dislocation. Okay, so let's go over a capsule tear. This one, these are recent. This is right before Thanksgiving. A lot of college kids are home and a lot of kids are being seen in the office. So he throws right, bats switch, And he plays all kinds of positions as a 15-year-old. He slid headfirst into base. This headfirst sliding thing is real. There's so many shoulder issues with headfirst sliding. Popped his shoulder back in. He felt it come out. He self-reduced it, and he has some examination features of instability. So here's our MRIs. See some edema pattern. And there's something funny going on the glenoid articular surface. You see that, Chris? You're our imaging expert today.
Oh, okay. Yeah, I agree completely. So he's got a little central defect in the middle of his glenoid with some edema around it, not a lot. Interesting, not sure if that's acute or chronic, but definitely worth looking at. But then a lot of edema around the anterior aspect of the glenoid neck, which would suggest an anterior inferior injury.
Okay, and this thing in the glenoid, is that a bare area? What is that thing?
Yeah, so there is a normal bare area in the central portion of the glenoid, but usually you're not going to see it on 4 or 5 consecutive slices. So if you start to see that on multiple slices and it's full thickness, you worry that something else is going on.
Okay, so this is a little bit of a tricky shoulder. He's got some cartilage thing that may or may not be normal for him, and he's got an instability event, and he's a thrower. It's his throwing side. And so without, I think we heard a lot of discussion about treatment, don't treat. Let's jump into the findings, and then we'll get out of the traumatic instability and get into some other stuff. So he's got some posterior labral stuff. He's got that thing. It's like a nice house for a little piece of cartilage. And then I didn't appreciate this so much on the MRI. What do we got here, George?
It looks like that case you showed during your talk. It looks like there's a capsular tear just medial to the labrum itself.
Yeah, how does that change things?
I mean,
All right,
that
well, I was.
needs to be fixed. That's how it changes things.
Yeah, now all of a sudden it's different. It's not just anchors, or maybe it is. Anyway, when I need to buy some time, I just start probing the biceps when I got to think about it.
So I think the question you're getting
think
to is what you
this-
hinted at in your talk. Do you just do a suture repair of this capsule to the labrum, or are you going to use anchors and advance the capsule up to the face of the glenoid, basically?
Yeah, I'm with you. Is it a good slap or a bad slap or no slap? Chick. Yeah, I thought so, but I just keep checking it and had to keep checking it. Okay, that's the capsule tear. Look how thin and whimsical that stuff is. So he did have some labral tearing in the back, and Jim Bradley used to drill in the bare area to get some marrow elements, so-called biologics, and just make a perforation and try and enhance healing. So I took one out of his playbook. Why not put a hole in that thing? And okay, we're fixing the capsule, and I don't think the technical features are essential for our discussion, but we did put some anchors in that are knotless, self-locking, and we chose to pass stitches through the labrum, almost like that posterior instability case, but we're passing through the capsule. It's a little tricky because the capsule is so flimsy. You got to put it on tension. It's hard to sew stuff. It's like sewing something that's floating in the ocean. It's just moving around too much. And our anesthesiologist is not controlling him. He's like huffing and puffing and moving. It's a rodeo. Okay, so
Was that kid his EUA, was he really loose?
he was loose.
Because he has almost like that hypoplastic labrum, I mean, it's there, but it's just,
Yeah,
it's pretty
flat,
small. Yeah,
flat,
flat.
flat
Yeah.
labrum. All right, so we fixed the front. It looks a little tight to me. I wish it didn't have to be so tight, Mike. And it's a little tight, and he's fixed in the back, so he's got a lot of fixing going on. He's the most successful part was that hole in the middle of the glenoid. So what's his prognosis?
Yeah, I think this is interesting in that fortunately this is his non-throwing side. So I think his prognosis is relatively optimistic. I do think he's going to be tight. And to Mike and all the physical therapists, sometimes we can't help it. Sometimes we do it on purpose, but sometimes we just can't help it. And you didn't have much of a choice here, so I think it looks great. But this being his non-throwing side, I think he's got a very high likelihood of doing well. He's also a switch hitter too, so he has a benefit to mix that up if he needs to. If this were a throwing shoulder, I'd be very concerned. I think would have a pretty poor prognosis, not because of the surgical technique, but just the nature of that injury. And a throwing shoulder is very difficult.
Given that he switch hits, would you let him hit right-handed first and then delay his left-handed hitting since this is his left arm, or doesn't matter? That's a
Uh,
legitimate question. I'm not,
Yeah, I am with you, George. This is a fragile shoulder. This isn't one that you just let him go, and it has to be very specific and adjusted with dose-dependent stress to his shoulder. So I would start out with minimum dosing on his way back and all of that. Everything about that makes complete sense to me.
So if this is a left shoulder and for left-handed batting, when can you start a hitting program?
I need a blackboard with all the lefts and rights right now.
I'm just curious what everybody
Yeah.
thinks.
Yeah.
So left shoulder, left-handed batting, when can you start a return to hitting
I
program?
think about too, to say back shoulder versus front shoulder when you're hitting too, so you don't have to, you get the right left out of it.
Yeah,
But if it's
yeah,
their
back shoulder.
if it's their back shoulder when they're hitting, I'll actually let them start a little sooner, around 4 months, post-op. If it's their front shoulder, I'm going to wait until 5 or 6 months. But I do think Chris is exactly right. It's not just get a bat and start. Like this has to be very slow, metered, thoughtful, and concentrated. And then to Peter's point earlier is oftentimes it's very difficult for a hitter who has a one-handed follow-through to switch to a two-handed follow-through. If you just ask them to do it, they can't do it. But since you're rebuilding the swing and you're taking them through a progression anyway, this is often a great opportunity because if you're going to start with just light tee work and you make them keep two hands on the whole time, sometimes you can get them to make that switch during this process.
Would anybody go any faster? I think I would do like Chris did.
No. I've got a question about post-operative immobilization. How long do we put people in slings? And is there any science out there behind what we're doing
Probably
with
not.
regards to sling use? Patients ask me all the time, how long do I have to wear my sling? You know, and when can I come out of it? When can I start doing pendulum exercises? You know, those sorts of things. Do we have any science on that? Anybody
No
in the
science,
audience have any thoughts on that?
no science. It's personal preference.
I think it's hard to do the science on that because the non-compliance with sling use is enormous. So 3-week or 4-week post-op, and the first thing I look going into the room is, where's your sling? And they say, oh, it's in the car. It's in the car?
But I've been wearing it every other day. Yeah.
Like it's in the
It looks
car.
like it came out of the box too.
Or-
It's brand new.
Equally annoying is you're about to examine. I'm like, why do you have your sling on? We're about to examine your shoulder. Get the sling off. You know, so anyway, if you have a sense of compliance, then you lean into the sling differently. So for me, if I see a 16-year-old kid and he's talking to me about the party and he's talking to me about all the things he wants to do, sling all the time, sleep in it, shower in it, you know, we get a little aggressive. If someone else is really timid, they're painful, fearful, they're getting stiff on exam, we get them out of the sling, play video games, start using your arm. Okay, let's talk about impingement. You guys good? Need a break? Hydrate, move those legs?
We're good.
It's another MRI, Chris, I know. You're ready. All right, he's 20, he's a college kid. So he's had a bunch of cortisone injections because his shoulder hurts. His first one gave him some relief, but now it's hurting and he's failing and his velo's going down. They all talk about their velo. And he's got the dynamic labral shear test and he's got weakness to his rotator cuff, external rotation, forward elevation. I showed this picture before because he's got an amazing internal impingement feature on his MRI scan. He had dye put in his shoulder. So I think to Hollis's point, the anterior part of his shoulder looks like it's severely damaged, but this is a feature of dye injection, not he destroyed his anterior shoulder. So sometimes, especially if you're looking for an anterior capsule tear and the radiologist is doing the injection, if they spray dye everywhere, it's a very compromised evaluation of the shoulder, depending on how they approach the dye injection. So I don't typically get arthrograms. In fact, why don't we go down the panel? Who gets arthrograms? Anybody? We got such good magnets now and everything. The one time I do get is subscap strain. I'm worried about an anterior capsule. Is that what you're going to say, George?
if your question was ever, sometimes I do, and I find in a revision situation,
Yeah.
it can be helpful. But as a standard primary MRI order, it's usually non-arthrogram.
Okay, so he's got, we'll call it internal impingement, and he's failing non-operative treatment, and he's had cortisone. What's the next step? He's 20, and as you know, college baseball players, they have a certain intolerance to, he's missing time. He's had months and months of pain. He's missing a season. He's gonna, if he continues non-operative treatment, it doesn't work, he's gonna miss another season, then he gets surgery. That's 3 seasons missed potentially.
So he had one subacromial injection that helped, and the other 2 injections were also subacromial or intra-articular?
I don't know, to be
Okay.
honest.
Oh, right, because he's second. And then is this pain the front or the back or
Yeah, it's in the back.
back?
Yeah, it's posterior superior shoulder pain, dynamic labral shear test with posterior superior reproduction of pain. It's internal impingement type pain. So it's acting like posterior labrum and cuff. Go ahead, Chris, you got.
Yeah, my general algorithm for these is that I agree, you know, we try to do everything we can to fixing the mechanical flaws in their range of motion or dynamic stability or strength. Try injections. You can try subacromial, usually intra-articular may be more helpful if it's an intra-articular problem, obviously. Cortisone or PRP, depending on the situation. But if that fails and we've got the motion back, we've got the strength back, but just still can't throw, surgery becomes the next option. And as we mentioned earlier, you know, when we're talking about shoulder surgery and the throwers, it's usually try to do the least amount possible to be able to get them back. So typically a debridement of the superior labrum and the underside of the rotator cuff if needed. But if the tear is bad enough, you may have to consider fixing it.
Okay, I like where you're going with that. So he's got this, it looks like a Hill-Sachs. It's not a Hill-Sachs, it's an internal impingement lesion. And I didn't have time to make all the videos. He's got posterior labral tearing. Does that stuff hurt in the back there? Doesn't look like it would feel good, but lots of guys have it who can throw through it. And anterior labrum's good this time, thank you. And so he's got undersurface stuff. We cleaned, and basically we did exactly, Chris, what you said. We cleaned up his tissue. We often talk about rotator cuff, Tom, about the cables. And this is just a nice illustration. He's got an internal impingement lesion on his humeral head, but you see that tissue in the back there? That's his rotator cuff attachment. So we can debride all day long. Rotator cuff, they could have tears all day long that are functional for them, adaptive, but that cable is important. Do you believe in that?
Yes, I do. I think I think it's uncommon in a thrower where that's going to go on to be a full thickness tear.
You guys know what we mean? George, do you have any thoughts about cable? And Neil Elatraj talks about it all the time. He's a cable advocate.
I mean, I think outside of the cable, and there's, I guess you call it an anterior and a posterior cable. If you're in that middle section, you can be fairly aggressive with debridement. And I've seen guys that you think they have a 70, 80, 90% partial thickness tear that doesn't involve the cables, and those guys do well. Whereas if it does extend to the cable, those are the patients that I worry about more. This one is not one I would be worried about because, as you say, it looks like the cable, the posterior cable is intact here for sure, and the partial tear doesn't extend to it.
Yeah, if I'm the supraspinatus and I got my 2 arms attached to the humerus, my arms are the cable. Then I got some other attachments, and those are the ones that tend to tear. And the posterior cable, which goes to anterior infraspinatus, sometimes that gets compromised. And if you lose the cable, you start to lose the rotator cuff function very quickly. So cable on is always more optimistic with his prognosis. So he just had a cleanup. We'll call it a cleanup. He got a cleanup. This is 6 months after surgery. He's throwing 120 feet. I just saw him last week, so I told Frank to take some video. And so I'm going as fast as I can. This is in real time. Because I examined already, I'm examining him again just for the video purpose. And this exam, Mike, I got my thumb and my fingers on his coracoid and his scapula. Dynamic labral shear testing, this was very positive before the surgery. And so he's feeling good. He's 120 feet.
Did you do anything subacromial?
I always put good question, Tom. I always put the camera in the subacromial space, and I have a different feeling than I think a lot of others do. There is bursitis commonly in these throwers when you operate on them and when you don't. So I do a lot of subacromial injections. Guys who are weak in external rotation, you do a subacromial injection. As soon as the marcaine, lidocaine is in, they get strong right away. I think we don't appreciate subacromial process. We started talking about it. Should we do a chromioplasty? I put the camera in almost every time on a thrower to check for bursitis. And if there's bursitis, I take it out. And it's always impressive to me. They have bursitis so frequently.
Chris, can I ask a question?
Yeah.
Because Chris Camp, made the assumption that we did the therapy, we got the guy's motion back, he did everything he could. What do you do with the guys who don't get their motion back, Mike? And is there a role ever for posterior capsular release in those patients in conjunction with what you did? So what happens to the guy who doesn't get his motion back? Not only does therapy fail to get him back to throwing, but it doesn't change the objective parameters of asymmetry of his total arc of motion.
It doesn't change his,
So you've been working on him and he's still,
right.
you can't get his motion back.
Internally though, because you mentioned
Well, you
posterior
tell me, how
capsular
do we
release.
know whether it's loss of external rotation or loss of internal rotation when they have asymmetry of arc of motion?
You can tell by adding it up and comparing it to the other side. It's usually pretty obvious, although lefties can confuse things, but that's a whole nother presentation. But for me, I think it's external rotation that I'm worried about. I very rarely see somebody that has a loss of internal rotation after surgery that becomes a problem versus somebody, if you lose a little bit of external rotation, you're kind of screwed.
Right, but I'm talking about the pre-op situation. We just talked about, Chris talked about how we spent all this time rehabbing the guy. We fixed his asymmetry of total arc of motion. I'm talking about the guy where you've done all that and you haven't fixed his asymmetry of total arc of motion and you get to surgery like we did for this kid. Do you ever address, do any of the panel ever address the posterior capsule with a posterior capsular release? Because he still has this asymmetry of his total arc of motion.
I'll show a case, and Mike Freehill demonstrated a Bennett's lesion, and the setting of a Bennett's lesion with a really hypertrophic posterior capsule, and then to even take care of the Bennett's lesion, I do release it and frequently do not repair the capsule. So it is like a release, and they typically have discomfort with the internal rotation. It's an internal rotation tension type of thing, but I have never released anterior capsular, posterior capsule just for motion restoration. I feel like there has to be pain in that area too.
Yeah, that's right. And then the literature would support that, what you just said, Chris.
You're operating on this kid because he still has pain. We sit here and we talk about, we think that the loss of internal rotation is at least part of the pathophysiology of this, but we're going to leave that part untreated. And you know me, I'm being devil's advocate here. I'm trying to stimulate some discussion. So there is pain. We attributing the pain in this case just to the cuff and the labrum and ignoring that loss of internal rotation that we haven't been able to correct? Or do we think that that may be contributing to his pain in some way? And are we setting him up for a higher risk of recurrence of these internal impingement issues if we haven't addressed a factor that we all believe contributes to it?
I think you're right, George. At least for me personally, I would give him say a cleanup operation first if I'm finding fragments of labrum, rotator cuff and so forth. And if he fails that, then maybe I would do an operation that's hard to undo, which is cut capsule.
I would say rarely I do. I had a kid recently, I mean, an excellent physical therapist worked on him for a year. And basically a totally clean shoulder, but he had increased ER of 10 degrees, decreased IR of like 50 degrees. I did a posterior capsular release. I looked in the subacromial space. I mean, is it the right thing to do? I don't know, but I'm not sure what, there was nothing to clean up too, by the way. His labrum was like pristine.
Did he get his motion back? Keep it?
I just did it a few weeks ago. Yeah, I'm buying him a one-way ticket to Boston though.
So that's a big case. To be devil's advocate of the devil's advocate, what's the devil's? To be that, I would, if you think somebody has such a significant loss of internal rotation and they have consistent internal impingement, I would actually be worried that their internal impingement is because they have so much excessive ER. And it's their total rotational arc is just shifted so much posteriorly that that's just something they can't get over.
So can you help everybody in the audience and especially the devil's advocate? How do you make, is there something on exam that you do that you can differentiate that? Like you just talked about a guy who has an asymmetry of his arc of motion. You think he's got excessive increased external rotation and it's not the loss of decreased. I have a very hard time on physical exam figuring that out and what is the cause of the asymmetry of their arc.
Well, the torsion of the bone. I mean, so you can have somebody that just has such a huge arc. So remember, when you look at the studies that have been published out there, standard deviation in those range of motion studies are enormous, sometimes like 20, 30 degrees. So that's a huge arc to try to say that. So think about it, like with somebody that has 130 degrees of external rotation on their non-dominant side, and they only have 135 maybe on their dominant side, that's weird. right? So you start to see with that total arc, and then you look at the difference of internal. So when you do the math and you do the addition on the two, it's usually fairly obvious which one's the culprit. Sometimes it's loss of IR, don't get me wrong, but sometimes it's excessive ER, and that's what we see on a lot of these kids. Extreme long toss, weighted balls, 5 to 10 degrees increase in external rotation, and they can never get over that internal impingement. It's because of the huge ER gain, not the IR loss.
So,
And I'm not saying all the time, just to be clear. I'm just
Now, in that case, it probably is soft tissue problem. Because, we've got 15 years of torsion data with the Rockies. And it's interesting because the people that don't have enough humeral retroversion get shoulder problems. And the ones that have a ton of humeral retroversion tear their UCL, which is kind of interesting. So
Yeah.
it seems like a bunch of humeral retrotorsion is fine for the shoulder.
And maybe the
But they
lats
tear their
too.
UCL.
So, and that's it. Well, let's move on, but these are great comments, really fantastic. And I think we've all seen high-level throwers who lack internal rotation that are asymptomatic. So it's hard to, that's our job. That's why this is a, tricky game that we play. Okay, I saw this gentleman last month, and he's a Division I collegiate infielder. He's got shoulder pain, and it's localized to the posterior shoulder, and he's had some PT and some med seds, not for a long, long time. This is scapular dyskinesis. And so he's well developed, and that's weak, right? So his rotator cuff's weak. Do you guys agree with that?
That's weak.
Yeah, he should be stronger than that. And having said that, occasionally we see suprascapular neuropathy where guys are weak and asymptomatic. Biceps is okay. But interesting, his active compression test wasn't that positive. And like everybody's got a positive active compression test. Okay, so he's got a weak rotator cuff. I'm going to lie him down and try not to trip on cords. What do you think of that external rotation? All this internal external rotation talk. What do you guys think of that external rotation?
it's not great.
Yeah, you could say it. Like he's not here. He's not listening.
It looks like Billy Wagner.
Yeah. Yeah, his external rotation is not favorable. Like that is not favorable for throwing. Okay. Okay, that does not look good. Can you fix that, Mike?
Yeah.
Tell us
So-
what you're seeing and tell us how you fix that.
So this is its right shoulder, right? So go. Can you pause it at the top? Is that no? You don't. You can't pause at the top. But if you show it, well, you can't even show it again, right?
I can
So
give
yeah, the
you-
left shoulder doesn't have a lot of control, but what you see on that right shoulder there at the top, watch on this next rep, how much more upward rotation you see on the right. So when you see more upward rotation without winging like that, and you can actually tell, can you play it one more time? You can tell when he raises his arms up overhead, his hands are together, but he has a huge deficit. Look at how much further away his arm is to the right. So he doesn't have overhead elevation. I think if I put him on his back on the table, he probably have 140, 150 degrees of overhead elevation. And that's probably all Terry's major, just locking that thing down. So we'd hit Terry's major, we'd get half of that motion probably back in one session and then just build on it over time. But we see that all the time. So Terry's major guys, infielder, probably has a lower slot, lots of reasons behind that. But, and just looking at him, he probably doesn't take care of himself very well. So he's a little beat up.
Hey, this is an example for me. You're busy in the office, you got a lot of patients, phone calls, agents called, you're running behind. You got to take their shirt off and you got to examine them from the back. Otherwise you miss this type of thing. And it could have just said, hey, you got a weak rotator cuff. Here's an injection, some medicine, keep going to therapy. And this deserves a phone call to the therapist and say, hey, we got some work to do on his scapular positioning, mechanics, anterior tightness. His pec minor is probably crazy tight and so forth. So he's got some MRI scans. I don't want to make this all about the MRI, but I'll just show you. He's got some glenoid stuff. He's got some signal in his glenoid acting like, and his humeral head looks funny to me too. So he's acting like he's got a little bit of dysplasia, perhaps, and he's got maybe some glenoid OCD. So, but this looks like if he could get his, he's been playing, if we can get his scapula working. So this is a physical therapy strategy to me. Would anybody say do anything different? Like who's operating on this guy? All right, good. Let's talk about a bad slap. Schick. let's be bad about this. So he's 17 and he plays in the infield and he's a pitcher. His shoulder's unstable. He's got instability that increases with throwing despite PT and an injection. He's got the positive tests again, active compression test. So here's his MRI scan. And just because we know this is a slap case, he's got a cyst in his head. What do you make of the superior labrum? And I wish we had a pointer, so I apologize. There's no way for me to manage showing what we're looking at with superior labrum.
Well, it looks like he has some partial detachment of his superior labrum right at the biceps anchor, and I can't tell if it runs into the bicep tendon or not. It may. It may. Right.
Showing it. So let's make this a, here are the axials. See the edema in the posterior head that's consistent with the internal impingement process. That cyst, I think, is incidental on the right. All right, let's put the camera in. Okay, so let's go down the list. Tony, what do you think of this labrum?
I know it's obviously pathologic, and I think this is a bad slap. This is the anterior part of his shoulder, and this doesn't, you did the dynamic labral shear and all of that, but it's, you're going to have to fix this and you'll leave the biceps alone. But I think that this is a problem where he's got such a large labral tear. Your focus here is to make his shoulder stable, and you'll do the best you can to get him back to his overhead sports. But I think you have to focus on repairing the labrum as best as possible. And that's going to include, to me, it looks like both in front and behind the biceps, which we don't like to do, but that's what I think you
All
need.
right, let's go down the list. I agree with you, Tony. Chris, is this a bad slap or a good slap?
No, very, very bad, very bad. And I think
Yeah.
too, also in the history, you alluded that he has a sensation of instability as well, that's a distinguishing feature between a bad labral tear and then just the good slap that is sometimes just painful or not.
He's got the anterior labral tear. Good, bad, Tom, and then George.
Bad slap. And I think you said he was first, third pitcher. I'd probably have a preemptive talk about how first and maybe third would be the way to go. I mean, this is bad shoulder for pitching.
George.
Bad. I think this is a, I don't know, type 9 slap. It extends all the way to the anterior. But exam under anesthesia, was he unstable anteriorly on your exam? Was there asymmetry compared to the other side?
Yeah, that's pretty common for me, which throwing shoulders, they're even in spring training. I mean, they're just loose on the front side. So it's hard to know if that's pathologic, but he's definitely translating, to the edge of the glenoid. Okay, Schick, if you don't think this one's bad, you gave us you taught us bad.
Yeah.
So let's talk about repair versus tenodesis.
That's
Who's
bad.
repairing this and who's doing a tenodesis?
How old is he?
20,
17.
17?
17.
I'd repair it.
Yeah, I don't think there's a good indication from everything you've told us to fix the biceps in this situation. If that tear doesn't go into the biceps and they don't have preoperative bicep symptoms, his problem is reconstructing his labrum and the stability of his glenohumeral joint.
Okay, anybody doing tenodesis? Nobody. Okay, good. All right, here I want to ask you technically, this is for the surgeons in the room because I've seen patients get tight after this. There's the suture passing device. Where do you guys put this thing? Where do you sew the labrum? This actually is we're passing a suture first. Do you go closer to the biceps than that? Further away from the biceps? Do you take more tissue or less tissue? And feel free. I don't feel like I'd like to hear how you guys do it differently. Teach me.
I like that. I go close to the biceps, but actually my one anchor up there, I'll do a mattress stitch rather than a circumferential stitch around so that it tacks it back down, but is not overstrangulating it.
Okay, gotcha. Okay, who's going closer to the biceps or further away from the biceps? With the idea that sometimes if we're in the biceps, we're just constraining the biceps. Biceps got to move a little bit.
Yeah, I think what Chris is saying, and which I agree with, is that how close you're to the biceps is where you have to really focus on just fixing the labrum and not incorporating the entire biceps, because the biceps comes all the way further back. And if you wrap up that entire set of tissue, you will constrain the biceps. So I think by moving it more onto towards the glenoid side, you're really just fixing the labrum. You'll use a mattress type configuration. And as you get away from that upper part, you can then do a complete, as you've done here, with all the way around the labrum further away from the biceps.
Yeah.
But
Okay.
I think you've constrained the biceps a little bit here, but honestly, this is a case where that's going to be okay because his problem is instability. And he might be a little tight, but I don't think you're going to end up with biceps problems in this one. You're going to fix him around the front and the back, and he's going to be able to get back to his sport.
I agree with you. This looks a little closer and more constraining the biceps, but his biceps was so unstable and he has a feature of instability. So we're erring towards over constraining his biceps. And if you have over constrained biceps, it doesn't feel good. Okay, George, I love your opinion. What would you do differently?
I would, that first anchor that's closest to the bicep, I would move a little bit more posterior away from the biceps, and I would do a mattress as Chris talked about, and then I'd do a second anchor circumferential like you. The big question for me is what do you do anterior to the biceps? Not the anterior inferior labrum, but anterior to the biceps, so the anterior superior labrum. Do we address that? Because that's a place where I think you need to be very careful with how much tissue you take. If you take a large bite of the soft tissue there, you can certainly over-constrain and reduce the external rotation. So if you put an anchor anterior to the biceps, that's a place where I'm very careful to get labrum alone. I'm not sure I'd put an anterior anchor in this kid in front of the biceps, but I would certainly address the anterior inferior component of the labral tear.
Yeah, we took care of all the anterior inferior. I made this about the bad slap. But everything got fixed in the front. All right, those are all great points. I
Did
agree
you put
with-
an anchor anterior superior?
Not on
Not.
the.
Slap.
Not on the slap area. I find that to be miserable, and there's some other people who have great results. I have never been happy with it.
I agree with you. I would not put an anchor there in this case.
Lose external rotation and so forth. So, all right, he got back to playing. This was an older case, and he's doing okay after this and fixing it in the front. Okay, let's talk about failed slap. He's 19. And he's had a slap repaired 2 years ago. So he has not gotten the back to play after an operation, spent 2 years. And he says his pain is exactly the same as it was before the operation. And I'm not sure why this is so whited out. It's iPhone.
And when you said his pain's the same, you were pointing to the front of his shoulder?
Yeah, that,
So when we,
good point. This is his pain, pushing on his biceps.
yeah,
And I have this conversation. I push on his biceps and I say, does that hurt? And he says, yeah. And I say, is it the pain you have? Because if you guys push on your own biceps, a lot of people have a tender biceps. Is that the pain you have when you throw that stops you from being able to play? And some people can articulate it. They're like, that is it. And then I'll say, if that pain goes away, do you think you could play? They're like, yeah, I can play. Okay, so his cuff and everything looks okay. His labral shear test is good. His external rotation looks pretty good. His internal rotation looks pretty good, right, Mike? Not so bad there. And then I did a little bit of, I gotta dye my hair with this phone.
That was a key too, Chris. I saw you just pointed to the back of his shoulder and he said no. So not having any posterior shoulder
Yeah.
pain, because often the superior labral tears will hurt kind of right in the back. And
You see
he
that?
clearly
He's,
said no to that.
sorry to interrupt because the video was going, he was clicking right there and he was saying that bothers me. It's consistent with his pain with adduction, internal rotation. Sorry to interrupt, but the video was going, what were you finishing
Yeah,
that
so
thought?
we were saying, it looked
Yeah.
like you were pointing at the back and asked me if he heard it there, and he
Yeah.
said no. So it seems like it's all in the front. So I think, true superior labral tear will often have pain sort of back at the joint line that feels like it's deep seated. So that's a key point to pull out.
Okay, he's got pain and so we're gonna put the camera in and see what we can fix. Okay, what do you think of that anchor position and the status of his shoulder? Maybe he's got micro instability. There's a big recess there. What are we gonna do here? George?
Well, I would want to assess the stability of the biceps tendon. I'd also want to see the upper portion that's in the groove to see if he has any groove pathology. It looks like they did a 2 anchor slap repair, one anterior, one posterior. I would certainly do what you're doing there, remove that anterior anchor for sure. And it looks like they may have done a partial debridement of the biceps right at the anchor. The tendon looks a little bit irregular there. This is a kid who's probably looking at a tenodesis, but the question I want to ask is why not just a tenotomy?
Yeah, good question. By the way, this instrument that's used to cut the suture, it's really good as a grasper. It's like the best grasper that you can find. You squeeze it without cutting it. It's like a grasper. It's like jaws on the thing, so you really can pull stuff out. This one didn't come out as easily. This one was more locked in. Okay, so now we got those anchors out. Schick. Is this a good slap or a bad slap right now?
That's a bad one. Leaning towards very bad and very concerned about that bicep.
What makes it bad?
I think the quality of the tissue is horrible. It's very unstable and it extends into the bicep.
Okay, I'm thinking this is like I mean, it's not good, it's ugly, but it's not bad in that it's like dysfunctional. I'd rather have it like this than with those anchors in.
Well, for sure. And you may have already done him all he needs to have done, get that out of there. That might be all
I
you
think
need to
he's
do.
rolling back and extra rotation. This is like adaptive stuff. If I had seen this exam, I would not have fixed this primarily. Would you guys, if you saw this exam, would you be fixing this thing?
I don't think that's where his problem's coming from.
Yeah, so he's got a tender biceps. And then he's got this, I do this exam under anesthesia with the camera in. We're trying to see his biceps if it incarcerates. And I got enough reason. He's had 2 years of shoulder pain, and we're going to do more than just take those things out to fix him. So we cut his biceps and we fix it arthroscopically, super pec, low in the groove. I still use a screw. I think it fixes it very well instead of just, say, suture anchors in that area. I've seen other people come in with dropped biceps after that. So a little academic here, but we get the tension right and we fix it. And so this kid's playing now and 2 years not playing. So I think there is a role for tenodesis in these salvage situations. He's not a pitcher and so forth. So I'm going to show you another case. She came in, this is a Thanksgiving home from school situation. She's a collegiate softball player, 7 months from a slap repair. And let's see if I can get this to play. This is her video. And she's saying it hurts right there.
Is she a position player or a pitcher? Do you know?
She's a position player. She's a catcher. Right, Frank? Usually I just ask Frank, who's here. So what do you think of this motion?
It's tight.
Yeah, she's too tight. Tom, she's too tight.
Yeah.
She is tight.
They do a really good job.
Anyway, she's 7 months from the surgery. Is this a just keep going and keep grinding and you'll be okay? I just saw her for the first time last week, so I can tell her what you guys think when I see her back.
No injections yet?
No, she 7 months from the slap repair. I saw her last week.
I mean, you could try an intra-articular injection and more PT and see if you can get her motion back. I mean, I'm not saying it's going to work, but.
Okay,
it's not-
more
not
PT and
unreasonable.
injection. And,
Yeah.
Okay.
The other thing to distinguish too is a tight shoulder after surgery. You gotta, was it because it was over tightened at the time of surgery, or are you dealing with a frozen shoulder adhesive capsulitis? And based on the way she's responding to that exam, this does not look like a frozen shoulder or adhesive capsulitis, but that is something to keep in mind. That tends to respond very well to a corticosteroid injection intra-articular. So I think it's reasonable to try, but it's less likely to be successful if they're tight because it was over tightened at the time of surgery.
Yeah, agreed.
Okay. Anybody going to do any imaging?
Yes.
Yes.
Oh, she's loose. So, she's typical ligamentous laxity.
Did she bring her intraoperative photos for you?
She did not.
No.
No, but I agree with you. It'd be nice to know what's been fixed and how it was fixed. And There's some old school slap stuff. We talked about the evolution of it. And so part of this was saying, we're trying not to over constrain with the stitches and the things that we put inside. They're miserable after that. And 7 months, you should be better than this. So as you get further and further out from the surgery, motion restoration starts to get less feasible.
I've seen some people prognosis wise in this manner where she's been trying to throw through that tightness for so long that it's just so irritable, and it almost has that bounce back tightness that she gets from it. So, I'd say prognosis wise, I do agree with the like shut her down, injection, see what we can do. I wouldn't give up on her. Sometimes people are so irritable from trying to throw through tightness, but yeah. I'd probably do a biceps tenodesis.
All right, this is a different case. So 18, he's a freshman softball pitcher. So part of this was, this is what we really see in the office, not just the professional athlete, softball player, felt the pop, pain, both, she's a pitcher, so both with windmill throwing and overhand throwing, everything is positive, but she's got good strength. She's tendon over the bicipital groove. And I'm going to show you the video. I'm just jumping right to arthroscopic stuff that we see. So good slap or bad slap? Tom, is this good slap or bad slap or no slap?
It looks almost like normal anatomy, just like a little bit of a peripheral insertion. Looks pretty good.
I agree with you. Then I'm going to go back for just a second. I'm not trying, I'm trying to create a narrative here. That's what I do. I tell a story, but you see the biceps itself, there's like a little bit of, it's just fragmented a
Right
little
next to your
bit.
probe?
There's like a
Yeah.
crease right there. All right, who cares? Normally, like, who cares? But then I do this to her, and she had this as an exam in the office. This is this incarcerating biceps thing. She says her shoulder pops. So,
So you're internally rotating her?
yeah, internally rotating her so the subscap and the lesser tuberosity are driving the biceps into the joint. Do you guys do this exam? Do you guys see this stuff?
Yes.
Chris, you do this?
I do, yeah, and also do it in the clinic too. And I found this to be relatively common or more common in swimmers as well. That's where I've seen it. So I've seen it in throwers, I've seen it in tennis players, but most common I've seen this in swimmers. So all sorts of overhead athletes is
Yeah.
something to think about.
That adduction into rotation. So, and you did some training at HSS. Steve O'Brien is a proponent of this diagnosis. And so I do think it's worth looking for. So we did a tenodesis. Now I'm going to share with you this one.
Can
And
you, anything on the MRI that would clue into that? I mean, because I'm presuming it's getting stuck in the groove and so it just can't slide, right? That's why it incarcerates, right?
Good question about what the local anatomy is with the version and the positioning and how it affects and how they do it. I don't have enough to tell you on that, but in a static MRI in that position, I don't know. I don't have
I
enough.
mean, do you see thickening of the tendon in the groove in these cases, or
I haven't,
anybody else have anything they can offer?
I haven't seen it on imaging, but I have been able to recreate it on physical exam in a few of these swimmers. So standing behind them and actually they'll usually kind of tell I'm feeling this pop here in the front of the shoulder, and I'll put my hand kind of where they're doing it, and I'll have them go through the motion, which is usually the same thing that you do on exam. Is you bring them in, bring them over, adducted, internally rotated, and you can feel a plunk and feel a pop there.
You could totally reproduce it in the office. I agree with you. And I showed it on the other case. Here's this kid's got bicipital groove pain. Here's an MRI scan with coronals, sagittals. I'm just jumping through because I wore Chris out with MRI interpretation. I don't have a pointer to show it, but he's got some posterior labral tearing, it looks like. What I really want to show was this arthroscopic exam, and he had that same exam finding, Chris, with his biceps being the source of pain with internal impingement. And then he's got this. See this, Mike Freehill?
Yeah, it's a Bennett's lesion.
That looks like he's got some Bennett's there, and he's got a posterior capsular injury. Maybe that was good for him. Maybe that was therapeutic. Maybe it wasn't. Okay, superior labrum looks okay. Pull this in. What do you make of that red carpet that lives on the biceps? Guys-
Pretty hot and inflamed.
Yeah.
So very irritated, clearly some biceps pathology there.
I pull a lot of biceps in, some have it, some don't. Now I push on I see something that doesn't look right on his humeral head. And I push on it. The humeral head's extremely soft right there. You see the dent right there? And I see on some of those patients who have incarcerating biceps, they have a groove that's developing on their humeral head.
Yes, O'Brien talks about that, an area of chondromalacia right there where it tends to incarcerate. So it's a good place to probe, and this is a really good example.
Yeah, this is like, stop, I'm damaging it with a probe.
But I think this is a great example, Chris, because this kid, at least arthroscopically, you could make the case that any one or all three of those findings might be causing his pain. So I'm going to be interested to see what you did with that kid.
What do you think of this from a Bennett's perspective? And I know I don't have the imaging and I don't have it, and he already has a capsule tear that's right next to it. First, is this a Bennett? By the way, this guy Bennett described it in like 1942. I mean, it's like one of the oldest shoulder pathologies to be described in the literature. There wasn't even orthopedic journals. It was like in the Journal of General Surgery or something, because it was that early on. Is this a Bennett? Would you, from a MRI or from a arthroscopic standpoint?
I think it is. If it's bony, you're palpating it, it feels pretty bony.
Yep, it feels bony, but along those lines, there's soft tissue Bennett's too before they really fill up. It's just like hypertrophic stuff. So there's bone, and I think sometimes it's a combination, bone and soft tissue. Okay, I'm fatiguing our faculty. It's almost time for lunch.
I mean, what's the question? I think it's a Bennett's lesion.
Yeah.
The next question, what to do with it?
Yeah,
I would exploit that capsular tear and I'd debride the Bennett's lesion without taking down the labrum.
I didn't even call you for help on this case. Okay, I like it. And so Mike showed some techniques on how to deal with the Bennett, and we got that capsular tear. So I'm doing it just a little bit blind because I'm not sure if it's his diagnosis, but I feel like if we're going to manage this, we might as well try to give him the best chance of coming back. We might as well do a little cleanup there. So did a little bit of debridement with a shaver, and it was a little bit blind, wasn't visualizing it, and then put the camera in, have a spinal needle just to pull the tear down, and then we'll see that there's some bone that's been removed. By the way, the Bennett's lesion, traction, posterior capsule, traction, internal rotation follow through. It's pulling. It gets fibrotic, tendinotic, pulls on the bone gets activated, the bone grows. Okay, we clean up some Bennett's lesion. Look, it's all soft now. And by the way, that Bennett's lesion, besides pain and follow through tension on it, if it's really big, when you go into the throwing external rotation, it causes more internal impingement because you bang against it with the rotator cuff. Okay, so
Did you do anything with the capsule?
you want me to?
No, I mean, it's just
Oh, give me-
super
Tell me what you
interesting.
want.
I wouldn't do anything to it. I was just curious if you did.
Okay.
That's
I
kind of an
just-
odd finding though, just that posterior capsular tear like that.
Yeah, I actually fixed it, and I'm with you. I don't fix Bennett lesions, but this was like an acute tear, and I questioned, was this therapeutic for him to tear it? And George,
Did he have an injury? I must have missed that part.
George may have, was saying that we maybe should have a different threshold for cutting capsule. You cut one the other day, so you're certainly not fixing this one. Anyway, I feel like the tissue is so like flimsy in that area, and there is a dynamic posterior instability. He's pulling on stuff that's further and made more soft tissue laxity by taking the Bennett's out. Anyway, I did fix it, put some anchors in. It's probably too tight, and fixed his biceps. So, but I agree, it's controversial. I would say probably most people would not have fixed it. It felt like better to put an anchor or two in there. And I have a feeling those anchors and those stitches, they could be managed post-operatively. Like it could be undone. It's not stitches that pull out a bone. It would just get loosened up with rehab.
Tony, in your experience and your work that you've done on biceps tenodesis, my understanding of your two papers is the vast majority of those were subpectoral tenodesis. Chris shows a suprapectoral arthroscopic procedure. Do you have enough data to say whether there's a difference between those two? Or if not, philosophically, why would you prefer the subpec to the suprapec that Chris did?
George,
The
that's
answer
next
to your
slide.
first, sorry.
I was just saying, that's the next slide, George. I like it.
So the answer to your first question is that there's not enough data to say one is better than the other. In the non-throwing population, they appear to be equal in the most recent series that have been done. So there's clearly been an evolution of the arthroscopic technique. The issue with the arthroscopic technique initially was that when you fixed it high, 10-20% of people may have persistent pain in the upper front part of their shoulder. And so then people started fixing them low, but the fixation devices weren't very effective. And so we had a much higher instance of the bicep slipping. And, these athletes don't like it when they get the Popeye deformity. It's whether that's functionally a problem or not, they just don't like the cosmetic deformity. And the subpectoral biceps tenodesis works so well because it was consistently done, and you can make sure the muscle of the biceps touches the muscle of the pec, so it's cosmetically looks great. So I think in today's world, if you're comfortable doing your biceps tenodesis arthroscopically and you followed your patients and you don't have this problem that some people still do but deny it, and that is that the bicep slips and they get a 1 to 2 centimeter gap, which functionally doesn't make a difference. But for athletes, they don't like it. But if you can do that and do it well, do it arthroscopically. Otherwise, do it subpectorally, because I don't have any problems with our patients in that situation. The last thing I'll comment, because I know Chris wants to move on, but is that there's this big issue about fracturing the humerus if you do a subpectoral biceps tenodesis. And, the fact is that most of those reports were done in older patients, women in their 50s and 60s. There's one report by one doctor. It was a 45-year-old master's level baseball pitcher with no preoperative imaging, no postoperative imaging, just a fracture. And you can see where they drilled the opposite cortex. So just saying that that's what it was. But they published it because they want to have the first publication in the journal. And I think that today we have a lot of fixation devices that can be very, very small holes, very secure, and work well. So it's going to definitely trend in that direction arthroscopically.
Great points, Tony. We have maybe one more case, and then we'll take some questions from the audience before we head out for lunch. Okay, we spoke about technique. This guy's a hard thrower. So this is, I wanted to show this as an older case. Mike Freehill's not with us. He gave the presentation on the Bennett's lesion, but this is yet another Bennett's lesion. He's got internal rotation, but he's got a rotational arc. If you look at the numbers, he's got maybe 5 degrees less of matching arcs, but he's got 35 degrees limited internal rotation, and he's got lots of positive stuff. Tender biceps, tender joint line, active compression test. And he's got an x-ray that shows that the inferior part right here, right at the inferior part of the glenoid, he's got bone. That's what it looks like on the CT scan. So he's got a Bennett's lesion. He's got a funny looking biceps on the MRI scan. That's what it looks like on MRI with that Bennett's lesion. So this is his first presentation of pain. Tom, I know you want to get this guy into therapy. What are we going to do for this guy? First presentation of pain with all this stuff on his MRI.
I mean, I would definitely try therapy. I think if you're questioning whether that Bennett lesion is hurting, I like Mike's idea of injecting it and see if that, takes his pain away.
But when you say injected, I want to make sure I understand that. And George has educated us on this. Are you injecting? Tell us exactly where's the injection go? Or does it go multiple places? Like, does it go in the posterior extra-articular? Does it go intra-articular? Are you trying to get it into the bone? Or into the
I think I try and get it right,
attachment to the
right
bone?
around that bone there and have, I'm not good enough with ultrasound guided injections, but have somebody put it right on that lesion.
Yeah, so we would use,
you think?
we do inject these. We do it under ultrasound guidance and just go right after it.
Inject all around it, in the capsule,
Yeah, try not,
behind the capsule.
yes.
Yeah. Okay, makes sense.
yeah.
Yeah. All right, so he gets a intra-articular injection, did not give him a injection into the Bennett's lesion, and probably should have. I agree with everything that you're saying. And I'm going to work on his motion restoration with that internal rotation and go into a throwing program, and it doesn't work. And so
Did that intra-articular injection help?
it didn't really help.
Well, that's valuable in knowing that though. I mean, it helps diagnostically.
Yeah, maybe, but take a look at this.
be a bad slap.
All right, so he's got some bucket stuff
Actually,
going
that's a
on
good
here.
slap in the sense that that's an easy thing to deal with,
So,
right? It's a bad slap that has an easy solution. You're just going to debride it like Chris is about to do.
Okay, it's not easy. Yeah.
The problem with this one is similar to our last patient, that he's got multiple pathologies going. It's a superior labrum, it's his bicep, it's probably his posterior capsule, his posterior labrum, and it's probably his Bennett's lesion. So how do you know how much to do? I think that's really the mystery here. You don't want to do surgery on this athlete more than once. So I tend to take the approach of, you take care of the things, everything you think is causing his symptoms. But this is really challenging.
Okay, the arthroscopic story is just getting started.
I saw it. That's bad.
I've shown this case. I've only seen this twice where I don't know what horsehair description you give this thing, but what happened to this guy's biceps? And I accidentally stepped on the shaver to see if it was real. And it's real. That's just terrible tissue. Yeah.
And that's the problem with fixing the biceps. It's just a bunch of longitudinal fibers. And if you just put something around it, it's going to slip through there. So when you do a biceps tenodesis, you have to have a strategy that includes not only putting something around it, but going into the tissue itself and holding it all together, hoping all those fibrils are all together. Otherwise, it's going to slip.
All right, so we cleaned up, looking for other stuff to do, or decide what we're gonna do with this thing, start cleaning other stuff up, and then, so I think we'd all agree this biceps has gotta go, and then we talked about technique, so we cut his biceps, and now we'll go to the Bennett's lesion. So this one, I felt like needed to be managed. We already talked about it, so we made a hole and removed it. And so who's repairing this capsule, that thing right there, and who's leaving it?
Leaving it.
Leaving it,
Leave it.
okay,
Leave it.
everybody's gonna leave it. Chick, you look like you're,
It just looks like,
His IR was pretty limited.
yeah.
But nobody does posterior capsular releases.
Hey, I did one.
I'm just trying to see I'm trying to figure out how much labrum you've still got left up there on the glenoid.
okay, we did his pec, but anyway, I left it on that one because I
Yeah,
thought that was part
tend to
of this
leave it.
thing. Okay, it looks like they shut us down. Oh, they let us back in.
Does anyone do a tenotomy? George, you brought it up before. I mean, is that just a timing issue, or do you actually have a preference to doing a tenotomy alone in some patients?
If we're talking about the overhead athlete, I do not do a tenotomy. I can't give you a good reason why. You articulated that you think the athletes don't like the Popeye deformity, but I just haven't made that move to a tenotomy alone in the throwing athlete. In workers' compensation patients and older patients, guys with big arms, ladies with big arms, I do tenotomies frequently, but not in this population. It's been tenodesis, subpectoral tenodesis.
Okay, let's take some questions. I have a latissimus case, and that would be our last case. We have maybe 10 more minutes. Does the audience have any questions? There's a big faculty here with a lot of knowledge, so take advantage of them. If you have a case at home, yeah, go ahead.
If you're doing a steroid injection and determine they need surgery, is there a certain time frame you wait prior to operating?
Yeah, great question. You want to take that, Tony? Much different if you're putting implants in like an arthroplasty.
Yeah, there's a variety of different resources for this, but when we looked up the Pearl Diver data some time ago, and we were looking for shoulder arthroplasty cases, what we found in a very large series, thousands and thousands of patients, if you did a shoulder replacement, put in a big piece of metal, within 3 months of having a cortisone injection, your infection rate went up. And when I say went up, it went from 0.3 to 0.6, which means it doubles. So why take that chance in an elective procedure? And then there has been additional studies since then looking more at soft tissue like rotator cuff. Does it affect the ability of the rotator cuff tendon to heal? And it's probably less time that you have to wait. If you want to be really safe, it's 3 months, but I think a lot of people are talking about 6 weeks, should be 6 to 8 weeks if you're doing a cortisone and doing a soft tissue operation. I still think it's wise to consider a 3-month gap because I think the cortisone and the anti-inflammatory effect can last that long. And inflammation is part of the normal healing process. And without that, you're going to increase your infection rate and you may reduce your healing rate. When it comes to labral tissues or debridements, it probably doesn't make a difference at all. So I think if you're trying to get tendinous tissue to heal and you're injecting cortisone, it's probably in your best interest, or you're putting in metal, it's probably in your best interest to wait 3 months. And then I think you won't have any liability if there is a complication after that period of time.
I'll add, that's great, Tony. I'll just add, some patients will say, I'm having surgery January 7th because that's when I have time off from work. Inject me now to carry me over till January 1st. And I'll say, not a good idea. I don't inject people for the, take care of their window before surgery for all those reasons.
Speaking of injections, one of the questions I want to ask the panel is, earlier we talked about internal impingement and, injecting athletes. What's the panel's thought on corticosteroid versus PRP? Let's say for internal impingement, just sort of the most common thing that we see. What do you do most commonly, and what decides that?
Yeah, I'll just take it first. We've all gone through this phase where the companies actually put the centrifuges in the training room to encourage you to use PRP. So cortisone doesn't always work, so we try the PRP and go from there. I just think the evidence for something like internal impingement and the use of biologics is very poor. And I don't think we have, people have looked at it in a lot of different ways. They've looked at it for the UCL, they looked at other things in Major League Baseball hits database, and we just don't have a lot of really strong evidence that it works. So I think it still comes down to a theory and just the belief of the physician, but we typically would start with cortisone and give them a period of recovery. And then if we're starting to think about surgery, but we don't want to go there, there might be a last ditch effort to try some biologics in that setting.
Yeah, I think I would be almost identical. Initially, it would be steroid. And if they had a great response and then it wore off and they're like, maybe I don't want surgery, is there something we can do longer lasting, try the PRP. Now, whether that, works, who knows, but I would kind of take the same approach.
Overwhelmingly, it's corticosteroid, and part of that is based on the fact that PRP for this condition is not approved by insurance. And at least in Missouri, there's not a lot of people who want to dip into their pockets for $1,500 for a PRP injection. So it's part driven by insurance, but from a medical perspective, my first go-to is a corticosteroid for the internal impingement.
And I will say one other thing is that, we're not the only ones injecting this stuff. And so when you get into a very competitive metropolitan area and you have physical medicine and rehabilitation and other people injecting it, they'll tell some of these athletes, if I can put that PRP right where your partial thickness cuff tear is, it should heal it up and you'll do fine. And there's zero evidence that that actually happens. But you hear that from your patients all the time, that not only is it going to solve their inflammation, but it's going to restore tissue. And I would love to see those studies.
We do a lot of ultrasound guided injections of a variety of different substances for a variety of different problems. I personally don't do the injections. I have a primary care sports doc that does those for me. Very anecdotally, he will inject a PRP. He will do a PRP injection at the request of a patient if the pathology seems to be cuff related. Primarily, and they're trying to get an anti-inflammatory effect, not necessarily a healing effect from that. At least that's how he counsels the patients. What we have found is that for isolated labral pathology, isolated in quotes, of course, because most of these things do come with concomitant problems with the cuff. But if you think you're just dealing with a labral problem, we've had zero success at all with any PRP injections. So that's kind of been our approach to it. And I think it's the out of pocket for us. I think it's $500.
Great points. Sometimes seasonal timing affects it too. If you have a big window in the season, somebody has a chronic situation, then PRP, like a patellar tendonitis, quad tendonitis, bad rotator cuff, end of season PRP is a little bit on your side for a slower, more biologic approach. In season, cortisone tends to work faster and has a chance of getting him back.
Sometimes the PRP also just buys you time when they buy into rehab. Gives you a little more time. Let the rehab.
Chris, do you believe that PRP works for hamstring tears, partial tears? For hamstrings?
For a muscle strain, I believe it does.
Or for a partial tendon of that.
Myotendinous and
Yeah.
tendinous, muscle, myotendinous, I believe it works.
Yeah. Because
And
I think we're coming up on latissimus injuries, and it's anecdotal because we don't see them a lot. Mark is correct, we see them a lot more. But a lot of these patients with these type 2 tears, they seem to respond very nicely to PRP. I mean, some of them get better very quickly, have a lot of blood in their shoulder, and it gets better and they don't hurt. But if we're going through a non-operative management and somewhere between 2 and 6 weeks, they're still having more soreness and inflammation, it's anecdotal, but PRP has seemed to be valuable, and people are much less likely to put cortisone at a myotendinous junction area. So in LATs for non-operative care, that might be a place where you might consider it.
all right, let's do a lat case and then let's have some lunch. So he's 19 and he's throwing in a bullpen. He feels a tear. He's got an MRI scan. Sees a physician who says you need an operation and is scheduling him for surgery, but he wants a second opinion. So I see him just recently, and let's see if we can get this to play. Okay, video is not playing. Okay, I have an opportunity to let you know that I did the best lat exam of my career. It was amazing. I mean, I got this lat, it popped out, it spoke, it did everything. Sorry, and we had all the videos working today, so thanks, great job by the AV people. Let's go with a picture. And Tony, this is his appearance. It's his right shoulder. And so he's got some deformity there. And he's got discomfort. And tell us what you think.
Yeah, I mean, I, based on what you're telling me from his exam, he sounds like he has a lat tear. And it looks like there's it could be, how soon is he after his injury?
2 months.
Oh, 2 months. Okay, so I was gonna say right after the injury for a few weeks, they get a lot of swelling from the blood. Some of these bleed quite a bit. And, but this is probably just a little bit of looking at this, if this is a lat tear, I would anticipate this is either extensive 2B or a 3 that's pulled off, and they've got that lump, and they can actually feel that lump in their armpit.
So what's the next step for him?
Imaging.
Imaging. Okay, this is where we get to go to lunch because he came in with his MRI and he's scheduled for surgery. And this is the MRI. It's a full chest wall MRI, a massive field of view, like it captured his whole body. And so the resolution to even find the lat in this is like impossible. So it said something like on the MRI, possible lat injury, and he got scheduled for surgery. So there's a point here, and that is latissimus injuries are a little tricky. I went through a little learning curve. Standard MRI scan, if you guys know how the MRI works, some guy makes a box around what they want to image after they do a scout view. Sometimes you have to capture a little more inferior. So we've developed a lat protocol so that you get standard shoulder MRI, but you have to go lower. And we don't ideally let the patient leave the scanner until we've had a radiologist feel that they've had enough lat image to make a diagnosis.
So to help you out, if you're reading your own x-rays, when you look at this standard MRI and you're going down the humerus and you see the circumflex vessels, that's where the lat's starting. So if that's where you see there's nothing below it, you're not even seeing the lat yet. So where the circumflex vessels are, then below that is where you're going to look for your lat attachment. And so you just make sure that they have their field expanded, or like Chris said, I like getting the lateral chest wall views. Hollis says that she just gets them further down and she reads the axial views, which may be fine for diagnosis, but I prefer for both treatment and understanding where I'm going to need to do my surgery to get the lateral chest wall views. That helps me visualize it better.
Great point. So we do a standard shoulder and a chest MRI with a chest coil, but it's honed in. The window is resolving mostly on the lat. You don't need to see the hard and all that. It just goes on the lat. They're in the scanner for a little bit longer. And sometimes they have muscle strain outside of the tendon that's farther down, which you can miss on a standard shoulder in addition to the lat injury.
We do a lot of musculoskeletal ultrasound diagnostically, and we've got some very, very slick radiologists that help us with that. Is anybody on the panel using an ultrasound to help with this, particularly a situation where they come in with this crappy MRI, insurance says, no, you can't get a new MRI because you just had one? Is there a role for
Yeah.
diagnostic?
I think in the training
ultrasound?
room or immediate assessment, or when you're trying to supplement your MRI or you don't have an MRI, you can see these full thickness tears pretty well. And a good ultrasonographer can pick this up without a problem. So I think it can be helpful for diagnosis. I don't think it helps me to understand treatment as well, but like we talked about, we're coming to sort of this watershed. If there's any part of it attached, then we're most likely going to lean towards non-operative management. So the ultrasound can at least get you going in that direction. And if you do an ultrasound, that's part of the tissues attached, and you start doing non-operative care, you've not missed anything. You get the MRI the next time they come in. If it's completely off, then you probably should push for getting a better imaging study.